student nurse today. Can I get your name and date of birth?
Jordan DeMaster, 12/5/1991.
Thank you. So I'm going to be doing a cardiac assessment on you today. So what I need you to do, I'll just ask you some questions and I'll kind of take a look at your chest area, and if it's okay, I'll listen and kind of feel your chest for any abnormalities and that kind of thing.
Absolutely.
All right. So I'm going to start with questions. Are you currently having any chest pain or difficulty breathing right now?
No.
And if they do have a history of chest pain, I would ask about the onset, what they were doing before they got the chest pain, any alleviating factors, and how long the chest pain would last. If they had any difficulty breathing with the chest pain, then I would, do you have any difficulty breathing on exertion?
I do not.
Any difficulty breathing lying down?
I do not.
If they would have difficulty breathing lying down, how I would grade the orthopnea would be how many pillows it takes, or how many pillows they use at night to sleep. Do you have hypertension or high cholesterol?
Do not.
Another way I could ask this question too is to ask the patient what types of meds they're on, because sometimes people don't really know why they're taking the meds they're taking or don't really think about it. They just do what their doctor said. So if they're on cholesterol medications, you can kind of gather that they may have high cholesterol. Do you have any major surgeries in your past at all? Okay. So what I'm looking for is previous cardiac events or any valve replacements as well, because an artificial valve sounds different than a natural valve, so I want to know that before I'm listening to them. And then I also want to assess kind of lifestyle. So I'm going to ask them if they smoke, if they do smoke, how many packs a day, if they drink, how many alcoholic drinks per week, and then per day. And I want to ask them about their diet, but I'm going to have them walk me through kind of what they eat in a day, because healthy and unhealthy can be kind of subjective, according to each individual. And then I want to ask what job they do, because the environment that they're in can sometimes progress diseases and that kind of thing, if they're breathing or sedentary, breathing in harmful chemicals. And then I want to assess any family history of myocardial events. So once I've kind of covered all of that, I want to inspect the chest area. I'm just looking for any lifts or heaves that you could see. Normally, the patient would have their gown down at least a little bit, or you could see that. And then you want to palpate. And so then you can feel any palpitations too if they're strong. And then you can feel for any thrills. And that's just a vibration of a very loud murmur. So I'm looking for that. And then I'm going to auscultate the heart here. I'm going to leave this out of my ear because it's kind of distracting to talk with it in. I'll put it in this ear. So what I want to do is kind of find that angle of Louis, because that'll be, and then I'm going to go like a finger breath to my left, their right, to listen to the aortic valve. And then I want to listen, go to the left, the same distance, and that second intercostal space on the sternal border. So the closure of the aortic and the pulmonic valve are so these are at the base of the heart, and this is where you hear the S2 heart sound. So that's the diastolic heart sound, the second heart sound that you hear, the dub. And to hear the S1 heart sound, you listen at the apex of the heart. So it's the midclavicular line at the fifth intercostal. So what I would do, I would go aortic, pulmonic, Erb's point here. The tricuspid valve is at the fourth intercostal border, then to S1, and this one is the atrioventricular valves closing. So the mitral and the tricuspid valve. And this is the lub, so this is the systolic sound, so it's lub dub, lub dub. And then I want to look for any abnormal heart sounds. So then I would have the patient lay in a left lying recumbent position, so kind of like that, but on their side. And then I would switch to the bell of my stethoscope, because the S3 and the S4 heart sound are a lower pitch sound. So an S3 could be normal in the very athletic or the very young, but if they're older, it could be indicative of a mitral valve failure. And so you would listen for both of these at the apex of the heart as well. So in that same area, but with the bell of the stethoscope. And so the S4 sound is almost always pathological and suggests heart failure as well. So then the other thing too, while you're doing this, you're listening for murmurs, any abnormal heart sound, and a murmur is turbulent blood flow. So then you grade those on a scale of 1 to 6, 1 being the quietest, 6 being the loudest. So with the 6, you might feel that vibration and that thrill. And you want to ask them if they knew about this or if this is a new onset. And then you want to assess for pericardial friction rub. So what you'll do is have your patient sitting upright and leaning forward. And then you'll auscultate here and listen to the heart. And pericardial friction rub kind of sounds like sandpaper being rubbed together. It's a kind of a coarse sound. And that can suggest inflammation of the pericardium, endocarditis. And so then I would have another nurse come into the room too, because I want to measure if there's a pulse deficit. So what we would do, one of us would listen to the apical pulse, and one would listen to the radial pulse, and we would start at the same time and end at the same time after 60 seconds. We would compare our numbers. If they were the same, there's no pulse deficit. If they were different, we would take the difference, and that can suggest atrial fibrillation, a flutter, or PVCs, because that pulse wave just isn't getting to the periphery like it should. So then you can also have stenosis, and stenosis is a narrowing of a valve, and then regurgitation is that backflow of blood. So then what I want to do too, what I was assessing when I first came in the room too, I was already looking at their skin. If they were pale, ashen, or diaphoretic, that can be signs of heart struggle as well. And then I'm going to look at his forearms and feel. So they're equally warm, dry, pink. They have good color. And then I'm checking capillary refill too. So I'm kind of looking at oxygenation versus hypoxia. So with that capillary refill, I'm looking at venous sufficiency. And if it was insufficient, you may see in the legs, you might see blood pooling, edema, varicose veins. They may have superficial ulcers. They're a little easier to take care of than deeper ulcers. Their skin may be reddish brown on their legs, and if someone had arterial insufficiency, you might see shiny skin, thick toenails, lack of hair on the legs too, and what they may describe intermittent claudication. So upon exertion, they may feel pain, and then the pain is relieved when at rest. So intermittent claudication, venous return, and then I want to check as well for orthostatic hypotension. So how I would do this is have the patient lie down for 5 minutes. I would take their blood pressure and their apical pulse for 60 seconds. Then I would have them stand up for 1 minute and then take their blood pressure and their apical pulse again for the full 60 seconds. And then rest for 2 minutes and then do it again. If there was an abnormality, it would be a decrease in systolic by 20, a decrease in diastolic by 10, and an increase in apical by 20. So I would want to do some patient teaching on this. It could be for medications or it could be something more pathological, but you want to teach them when they come from a lying position to sit down and kind of sit for a minute to gain their bearings, make sure they're not dizzy or lightheaded before they stand up so that they don't pass out or fall over.